Hey everyone, welcome to KSSP Podcast. I'm Spencer.
And I'm Katie. Today we're going to be doing a series on how different drugs affect us, both neurochemically and physiologically. So to start, I just want to say that drugs are going to affect everybody differently. These are just generalizations, so they may not apply to you. The human body is pretty complicated and pretty individualized to each person. So it's also important to know that the listed side effects are a probability, not a guarantee. Not everyone's going to have the same experience using every drug, and some people may experience all side effects while others may experience none. So these side effects are also determined by how often and how much of the drug you are using, and if you are mixing drugs together. And I do just want to mention, when we say drugs, alcohol is definitely included in the list of drugs, because alcohol is a drug.
So today we're going to be going over a couple of different types of drugs, including alcohol, marijuana, hallucinogens, MDMA, benzodiazepines, crack and cocaine, opioids, amphetamines / meth, and PCP. And again, we're going to be going over how each of these affects us neurochemically and physiologically.
This is from OA text. This is how alcohol affects the brain. Let's just look at these different parts of the brain. So the hippocampus, your memory is controlled by the hippocampus, and drinking a lot of alcohol at one time can cause you to black out or forget a period of time. Long-term alcohol abuse can permanently damage the hippocampus, making it difficult for a person to learn. Then the hypothalamus. Many body processes, such as the heart rate and the feeling of hunger or thirst, are controlled in this small area. Alcohol can slow your heart rate and make you hungrier and thirstier. Then the central nervous system. So alcohol slows down this system, which is made up of the brain, spinal cord, and nerves. So this makes it a depressant, and that affects how signals flow through your body, making you think, speak, and move more slowly. We have the medulla. Involuntary processes such as breathing and maintaining the body temperature are controlled here. Drinking a lot of alcohol at one time can shut down the medulla, leading to a coma. Then we've got the cerebellum. This part of the brain is important for coordinating many of your daily movements, such as walking and grabbing objects. Alcohol can slow your reflexes, and it may cause you to lose your balance or make your hands shake. And then the cerebral cortex. This is the main area involved in thinking, decision-making, emotions, and the five senses. Alcohol's effects on this area can impair your ability to think clearly and lower your inhibitions. May make you act without thinking or make you angry for no reason. And alcohol may affect your senses, such as blurring your vision. Long-term alcohol abuse can permanently damage this region. So that's just a little visual to show how alcohol affects the brain. And the typical route of administration for alcohol is drinking. I guess I'll just add that there are other routes of administration as well for all of these. We'll just be listing the typical routes of administration, the most common ones.
Oh, yeah. Okay, and then we're going to move on to kind of more in-depth pharmacology of it too. So alcohol or ethanol. So identifying molecular targets for ethanol has proven unusually difficult, in large part due to its unique biochemical properties. Ethanol is a very low molecular weight compound and is of exceptionally low potency in its actions, causing effects only at very high millimolar concentrations. Although it has been established that ethanol modulates ion channels to mediate its effect, Ion channels are complex proteins, and their interactions and functions are complicated by diverse subunit compositions and regulation by conserved cellular signals, or signaling lipids. While no binding sites have been identified and established unambiguously for ethanol at present, it appears that it affects ion channels, in particular ligand-gated ion channels, to mediate its effect in the CNS. It can enhance or inhibit the activity of a variety of ion channels, including the GABA receptor, the inotropic glutamate AMPA kainate and NMDA receptors, the glycine receptor, the nicotinic acetylcholine receptors, the serotonin 5-HT3 receptor, voltage-gated calcium channels, and BK channels, among others. However, many of these actions have been found to occur only at very high concentrations that may not be pharmacologically significant at recreational doses of ethanol, and it is unclear how or to what extent each of the individual actions is involved in the effects of ethanol. Ethanol has long shown a similarity in its effects to positive allosteric modulators of the GABA receptor like benzodiazepines, barbiturates, and various general anesthetics. It is theorized and widely believed that the primary mechanism of action is a GABA receptor positive allosteric modulator. Findings suggest a binding site for ethanol on subpopulations of the GABA receptor with specific subunit compositions via which it interacts with and potentiates the receptor. This suggests that a metabolite, not the ethanol itself, can affect the primary targets of ethanol, intoxication.
Interesting. So, yeah, and lastly, we're just gonna go over this little picture here really quick. This is from the NIH, the National Institute on Alcohol Abuse and Alcoholism. And this is alcohol-associated organ damage. So, cardiac, aka your heart. Alcohol can cause cardiac arrhythmias, cardiomyopathy, ischemic heart disease, and hypertension. As far as your oral cavity, it can cause esophageal cancer and oral cavity cancer. And then with your liver, it can cause steatosis, which is a fatty liver, steatohepatitis, fibrosis, cirrhosis, cirrhosis is a common one, alcohol-associated hepatitis, and liver cancer. Then gastrointestinal systems, it can include gut leakiness, microbial dysbiosis, or colorectal cancer. Neurologically, it can cause ischemic stroke or hemorrhagic stroke, rather. And then with your lungs, it can cause acute respiratory distress syndrome. I'm assuming that's all one word. And it can also cause pneumonia. With your muscles, it can cause myopathy and wasting. The pancreas can cause acute or chronic pancreatitis. And the bone, impaired fracture repairs and reduced bone density. So, yeah, those are some of the side effects of overusing alcohol. It says marijuana's effects on the brain from Desert Cove recovery. And when many people smoke marijuana with THC, the lungs into the bloodstream. Many people may feel a heightened sensory perception, euphoria, relaxation, increased appetite, and an altered perception of time, which usually time ends up going really slowly. And then some people's effects are highly adverse and can include fear, distrust, or panic. And for cannabis, the typical routes of administration, well, I mean, there's a lot of them. I can't even list anywhere close to all of them right now, but Main ones would include smoking, vaporizing, an oral route, which would be edibles or THC capsules, and then tinctures and topicals. Those would be the primary ones.
And then we'll go into a little bit of, I guess, the pharmacology of cannabinoids with marijuana. So they have high lipid solubility, which is why they can persist in the body for long periods of time. And THC can be found in the body for weeks or longer. Investigators have suggested that this is an important factor in marijuana's effects, perhaps because cannabinoids may accumulate in the body, particularly in the lipid membranes of neurons. THC exerts its most prominent effects via the CB1 receptor and the CB2 receptor, which are G protein-coupled receptors. THC appears to alter mood and cognition through its agonist actions on the CB1 receptors. Via CB1 receptor activation, THC indirectly increases dopamine release and produces psychotropic effects. CBD also acts as an allosteric modulator of the mu and I think delta opioid receptors. So 2 of the opioid receptors. THC also potentiates the effects of the glycine receptors. And CBD can inhibit or induce the activity of cytochrome P450, which is a family of liver enzyme isoforms that the body uses to metabolize some prescription medications, which can end up increasing or decreasing the effect of these medications.
Yeah, so next we're going to list some possible side effects, some negative ones. There could be headache, dry mouth and dry eyes, lightheadedness and dizziness, nausea and vomiting, fatigue, drowsiness, disorientation, increased heart rate, increased appetite, and then hallucinations, and it can impair attention, judgment, and coordination. And we're going to look at some of this article by the NIH. Another one from them. So some short-term effects on the brain include altered senses, altered sense of time, changes in your mood, impaired body movement, difficulty with thinking and problem solving, impaired memory, hallucinations, delusions, psychosis, which the psychosis is a pretty rare risk, but it is a risk for some people. It just depends on your genetics. Let's see. And then there's been a rise in marijuana's THC levels. The amount of THC in marijuana has been increasing steadily over the past few decades. And for a person who's new to marijuana use, this may mean an exposure to higher THC levels with a greater chance of a harmful reaction. Higher THC levels may explain the rise in emergency room visits involving marijuana use. So the popularity of edibles increases the chance of harmful reactions because they take longer to digest and produce a high. And people may consume more to feel the effects faster, and that can lead to dangerous results. And it can also lead to a higher rate of addiction. Although it is fairly low risk for addiction, but it is still possible to become addicted. And then there's physical effects like breathing problems, increased heart rate, problems with child development during or after pregnancy. Let's see. I kind of want to read more about this one because I'll be honest. Everyone I've ever talked to who did smoke marijuana during a pregnancy never had complications with their kids. That doesn't mean it doesn't happen, but that's just what I've experienced. So this says it's linked to a lower birth weight and an increased risk of both brain and behavioral problems. This is according to the NIH, though. So other research suggests an increased risk of preterm births, but more research is needed. But yeah, everyone, I guess this kind of contradicts my experience, but that's what the data says, so. And I'm not encouraging people to smoke THC when they're pregnant or anything like that. That's not what I'm trying to say here, but yeah, that's just what I've noticed. And then can be intense nausea and vomiting. And there's been, of course, with the new vapes, there's been serious lung illnesses associated with the vaping of THC. Yeah, I don't agree with this whole article, honestly. Like, it talks about how it's not good for people with any kind of mental illness. But, like, that's really going to depend on what the mental illness is, if it can be medicinally used or not. Like, for example, it's medicinally used for, like, PTSD, for example. And it tends to have good results in most people. And then, we're going to talk about if cannabis really impacts memory. Because I find it kind of interesting about how THC interacts with memory. So there is evidence showing cannabis intoxication can change or distort short-term memory processing temporarily. And it seems to be caused by neural receptors responsible for memory that are disrupted by compounds in cannabis. The ability to learn, loss of interest, or problems with concentration have been shown to be linked to this interruption of short-term memory. However, cannabis has been shown to have a positive impact on neurodegenerative diseases such as Alzheimer's, Huntington chorea, and epilepsy by positively impacting patients' memory. Researchers studying mainly animals have found that it could slow or even prevent these diseases by creating neurons. And then recent discoveries show that we can't say that cannabis itself causes psychosis or that it is detrimental to memory. Other factors include the type of cannabis, the compounds it contains, that may indicate specific risks or benefits, for sure. So how the plant is bred, basically, and what compounds it contains. And additionally, it's hard to factor in the results for people participating in the studies who also use other substances such as alcohol, which does cause memory damage. And more frequent use of cannabis may also cause long-term memory issues. The more frequent the cannabis use, the more likely it is to impact your memory. However, these effects are completely reversible once someone stops using cannabis and can be reversed rather quickly. So, experimenting with cannabis should have very little impact, if at all, on your memory. It is the more frequent use when it is through more frequent use when we see memory issues. However, while this may be a risk, oftentimes medical cannabis use benefits outweigh the risks. This is from Pharmacological Reviews. So, psychedelics tend to increase neuroplasticity, dendritic spines formation and growth, axon branching synapse formation, and then it tends to decrease anxiety, depression, and PTSD. So we have ayahuasca, DMT, and 5-MeO-DMT, which activate the mTOR, BDNF, TRKB, NGF, ERK1, ERK2, CREB, CAMK2, the 5-HT2, AR, and AKT. Then ketamine activates the mTOR, BDNF, TRKB and the AKT. DOI activates the EGR1, EGR2, CFOS, and EGR3. And then LSD activates the mTOR, EGR1, the CEB, PB, the SGK, NEA3, DHEA, CFOS, EGR2, IKB, NOR1, MKP1, and DHEA. I don't know why DHEA is listed twice, but it is, I guess. And then psilocybin or mushrooms activate the mTOR and the BDNF. Then MDMA, which we'll talk about later, that will be activating the cortisol, prolactin, and oxytocin. And then our next image here is from drugrehab.com. This is the effects of hallucinogenic drugs on perception. So basically this is just showing our senses connecting neurologically. Here, thinks you hear sound, you think you feel a sensation, think it smells a scent, and you think you see something. So these are the effects of the hallucinogenic drugs on perception. Experts think the drugs cause hallucinations by disrupting communication between chemical systems in the brain and spinal cord. These areas of the nervous system are in charge of sensory perception. In the typical route of administration, so I'm just going to go over LSD and mushrooms. LSD is usually a sublingual, meaning that like it dissolves in your mouth. And with mushrooms, you typically eat them or you can drink them as a tea as well.
And then we'll go into, again, just some kind of pharmacology. And we'll have three kind of different ones for this one. So we'll start with dissociatives, the classical dissociatives. So classical dissociatives achieve their effect by blocking binding of the neurotransmitter glutamate to NMDA receptors. So NMDA receptor antagonism. They include ketamine, methoxetamine, or MXE, phencyclidine, or PCP, dextromethorphan, DXM, and nitrous oxide. Dissociation is also remarkably administered by salvinorin A, which is the active constituent in Salvia divinorum, shown, I guess, to the left. Not with us, but where I got this from. And potent K opioid receptor agonism, though usually described as a very atypical dissociative. Some dissociatives can have CNS depressant effects. They process pain as a kind of far away sensation. Pain, although present, becomes a disembodied experience, and there is much less emotion associated with it. So these are just some little effects of the ones that we just mentioned. So like DXM in higher doses can increase heart rate and blood pressure and still depress respiration. Nitrous oxide, the principal risk with that one seems to be due to oxygen deprivation, and injury from falling is also a danger, as nitrous oxide may have caused sudden loss of consciousness in effect of oxygen deprivation. And then because of the high level of physical activity and relative imperviousness to pain induced by PCP, some deaths have been reported due to the release of myoglobin from ruptured muscle cells. High amounts of myoglobin can induce renal shutdown.
We are going to talk about PCP in a later episode a little bit more as well.
Yes. And then we'll move on to deliriants. So, despite the full legal status of several common deliriant plants, deliriants are largely unpopular as recreational drugs due to the severe, generally unpleasant, and often dangerous nature of the hallucinogenic effects produced. Typical or classical deliriants are those which block the muscarinic acetylcholine receptors, so again, antagonism. These are said to be anticholinergic, Many of the compounds are produced naturally by plant genera belonging to the nightshade family Solanaceae, such as Datura, Brugmansia, and Latua, in the New World, and Atropa, Hyoscyamus, and Mandragora in the Old World. These tropane alkaloids are poisonous and can cause death due to tachycardia, induced heart failure, and hyperthermia, even in small doses. Additionally, over-the-counter antihistamines such as diphenhydramine, brand name Benadryl, and dimenhydrinate, brand name Dramamine, also have an anticholinergic effect. Uncured tobacco is also a deliriant due to its intoxicatingly high levels of nicotine. And then psychedelics. So while the method of action of psychedelics is not fully understood, they have shown affinities for various 5-HT serotonin receptors. They may be classified by their activity at different 5-HT subtypes, particularly 5-HT1A, 5-HT2A, and 5-HT2C. They produce their effect by acting as strong partial agonists at the 5-HT2A receptors. How this ends up producing the psychedelic experience is unclear. It's likely that it acts by increasing excitation in the cortex, possibly by specifically facilitating input from the thalamus, the major relay for sensory information input to the cortex. Researchers discovered that many psychedelics are potent psychoplastogens, compounds capable of promoting rapid and sustained neuroplasticity. So then we have tryptamine, along with other trace amines, is hypothesized to play a role as a neuromodulator on classical monoamine neurotransmitters such as dopamine, serotonin, and norepinephrine. Non-selective serotonin receptor agonists to activate serotonin receptors, and a serotonin, norepinephrine, dopamine releasing agent, SNDRA, to release more monoamine neurotransmitter with a preference for evoking serotonin and dopamine release over norepinephrine release. Psychedelic tryptamines found in nature include psilocybin DMT, 5-MeO-DMT, and tryptamines that have been synthesized in the laboratory include 4-HOMET, 4-HOMIPT, and 5-MeO-DALT. And then phenethylamine is also a trace amine. It acts as a neurotransmitter in the human central nervous system. It regulates monoamine neurotransmission by binding to trace amine associated receptor 1, or TAR1, which plays a significant role in regulating neurotransmission in dopamine, norepinephrine, and serotonin neurons in the CNS, and inhibiting vesicular monoamine transporter 2, or VMAT2, in monoamine neurons. When VMAT2 is inhibited, monoamine neurotransmitters cannot be released into the synapse via typical release mechanisms. Mescaline is a naturally occurring psychedelic protoalkaloid of the substituted phenethylamine class. And then amides of lysergic acid are collectively known as lysergamides. And there are a number of compounds with potent agonist and or antagonist activity at various serotonin and dopamine receptors. LSD, lysergic acid diethylamide, is one of the many lysergamides. 1P-LSD is a derivative and functional analog of LSD and a homolog of ALD-52.
Yeah, so now we've got another article from the National Institute of Health again. And so we've got the specific short-term effects of a few psychedelics here. So for LSD, there's increased blood pressure, heart rate, and body temperature, dizziness and sleepiness, loss of appetite, dry mouth and sweating, numbness, weakness and tremors, impulsiveness, and rapid emotional shifts that can range from fear to euphoria, with transitions so rapid that the user may seem to experience several emotions simultaneously. And then with psilocybin, there's feelings of relaxation, similar to effects of low doses of marijuana. There's nervousness, paranoia, and panic reactions that can happen, introspective and spiritual experience, which I think also applies to like pretty much any of these. I don't know why it's only on that specifically, but anyways. And then there's a misidentification of poisonous mushrooms resembling psilocybin, and that could lead to unintentional, potentially fatal poisoning. And we've got peyote, so that's going to increase your body temperature and heart rate. You're going to have uncoordinated movements or ataxia, profound sweating and flushing. DMT will increase your heart rate. It might make you agitated, and then these hallucinations frequently involving radically altered environments, as well as body and spatial distortions. Which the body and spatial distortions, again, are true. I mean, I've noticed that for all of them, honestly. That at least the ones I've tried in the past. And then there's ayahuasca, and that's going to increase your blood pressure. You could get severe vomiting induced by the tea, and then a profoundly altered state of awareness and perceptions of otherworldly imagery. So the short-term general effects of hallucinogens. The sensory effects include the hallucinations, and that includes seeing, hearing, touching, or smelling things in a distorted way, or perceiving things that do not exist, which, yeah, I'll talk more about that in our conclusion. Intensified feelings and sensory experiences, including brighter colors and sharper sounds, and mixed senses, which would be like seeing sounds or hearing colors. And then changes in sense or perception of time. Time goes by rather slowly. And then the physical effects include increased energy and heart rate and nausea. And then some long-term effects. Persistent psychosis is possible. It's pretty rare, but it is possible. It includes visual disturbances, disorganized thinking, paranoia, and mood disturbances. And then there's also another rare disorder, the hallucinogen persisting perception disorder, HPPD, which includes hallucinations. And this is after the drugs worn off. So this is long term. So hallucinations, other visual disturbances, such as seeing halos or trails attached to moving objects. And then symptoms sometimes mistaken for neurological disorders, such as a stroke or a brain tumor. So that's what the NIH has to say about that. And then our final article for today is about psychedelic-induced neuroplasticity from nature.com. This is from a study. So I'm just going to read a couple parts here. So in this study, firstly, they review the evidence that psychedelics promote neuroplasticity and examine the cellular and molecular mechanisms beyond the effect of different psychedelics or on different aspects of neuroplasticity, including dendritogenesis, synaptogenesis, neurogenesis, and expression of plasticity-related genes. So, for example, brain-derived neurotrophic factor and immediate early genes. And then next, they examine where in the brain psychedelics promote neuroplasticity, particularly discussing the prefrontal cortex and the hippocampus. Then they also examine what doses are required to produce this effect. So, for example, hallucinogenic doses versus microdoses, and how long purported changes in neuroplasticity last. And then finally, they also discuss the likely consequences of psychedelics' effects on neuroplasticity for both patients and healthy people, and they identify important research questions that would further scientific understanding of psychedelics' effects on neuroplasticity and its potential clinical applications. And finally, classic psychedelics are thought to catalyze a period of accelerated neuronal growth, enhancing the brain's capacity for neuroplastic changes. Studies in animals have shown that LSD, psilocybin, DMT, and DOI promote the expression of genes related to synaptic plasticity, including immediate early genes and BDNF. Furthermore, they catalyze a burst of synaptic and dendritic growth and can increase the strength of long-term potentiation. This picture here from the National Institute on Drug Abuse. These are just a list of the brain areas affected by ecstasy, and then they're color-coded here. So we've got the neocortex, the hypothalamus, basal ganglia, amygdala, and the hippocampus are all affected there. The typical routes of administration include typically either oral, so like either you take a pill or you mix powder with water, or otherwise people might snort it as well. So that's how people typically use it.
And then we'll go over some of the pharmacology of MDMA. So, MDMA increases the amount of serotonin in synaptic clefts by inhibiting serotonin's uptake, and it also directly releases it from the neurons. MDMA binds to various serotonin receptors and activates them in excess, leading to MDMA intoxication. It also induces significant norepinephrine release. And then extracellular MDMA acts as a reuptake inhibitor on serotonin, norepinephrine, and dopamine transporters. Its efficiency is highest towards the norepinephrine and serotonin ones. MDMA induces serotonin transporter reversal, leading to serotonin release. So basically, MDMA seems to increase the amount of serotonin and norepinephrine mainly in your system. And then also cortisol, prolactin, and oxytocin quantities in blood serum can also increase with MDMA use.
So once again, we've got another article from the NIH. These are just potential acute adverse health effects, so some potential side effects. Would be marked rise in the body temperature, hyperthermia, dehydration, electrolyte or sodium imbalance, high blood pressure or hypertension, involuntary jaw clenching and teeth grinding, muscle or joint stiffness, lack of appetite, illogical or disorganized thoughts, restless legs, nausea, hot flashes or chills, headaches, sweating, faintness, panic attacks, loss of consciousness, seizures, kidney failure, and swelling of the brain. And then there's potential longer-term health effects, so including those observed days or weeks post-MDMA use. There's arrhythmia or irregular heartbeat and heart damage that's possible. Irritability, depression, impulsivity, impaired attention and memory, anxiety, aggression, sleep disturbances, concentration difficulties, lack of appetite, heart disease, and decreased cognitive function. Then, so now we're going to talk about MDMA-assisted therapy for PTSD. And then this is from a WebMD article. Really quick here, we're just going to read a couple parts of this. So PTSD may cause memories to pop up as flashbacks or nightmares and force some people to relive terrifying moments. Severe PTSD can also lead to suicide. There is no medication to treat PTSD itself, but some medicines may ease symptoms. So treatments like talk therapy and cognitive behavioral therapy can also help. But almost a third of people drop out of therapy and up to 58% still have PTSD symptoms after they finish. And this is often because, like, if you have PTSD, like, once you go to therapy and you start to talk about it, the PTSD symptoms tend to get worse before they get better. So that's just why a lot of people drop out of therapy and still have the symptoms. And sometimes it even makes them worse depending on the type of therapy and when they drop out of it, like in their healing process. And then this is where MDMA comes in. So experts have found that when people with PTSD are given a certain amount of MDMA in a clinical setting, it helps them open up so they can work through traumatic events. And MDMA itself is not approved for legal use because of its history as a recreational drug with the potential for harm, abuse, and addiction. I mean, that's not really why it's illegal, but we already talked about that on Monday. And since 2017, the FDA has deemed the drug's beneficial effects on PTSD symptoms to be a breakthrough therapy. So that's what the FDA even said. So some other effects can include the feelings of empathy, self-awareness, sensory pleasure, more energy, less anxiety, ability to open up about emotions, and differences in how you see time and space.
And then I just have a little kind of image here that goes over how MDMA can help certain areas for like MDMA couples therapy. So we're just gonna, and some of them are like the areas of focus seem to be this, like they're probably different mechanisms from like for PTSD, but we're just gonna go over them and how they could help with couples therapy. And I guess they maybe have some similarities, but anyways, so first area of focus, empathy, and how MDMA supports. So oxytocin release helps increase interpersonal focus, feelings of interpersonal trust, and social affiliation. MDMA associated with seeing others as empathetic and caring and increasing emotional empathy beyond oxytocin alone. So their proposed therapeutic interventions to facilitate is centering both people's experiences, sharing of feelings. So communication, MDMA is associated with greater interpersonal focus and language, reduction in reactivity to angry facial expressions, and greater reward in happy faces. So that could present and practice skills of sharing and listening with both negative and positive content. Perception of social connection and support, reduction in feeling of social pain, decreased feelings of threat, increased feelings of interpersonal trust, increased identification of pro-social feelings, highlight strength in couples interactions, remind in integration to reduce the likelihood of returning to old patterns after MDMA sessions. Could help with non-avoidance. MDMA assists in fear attenuation, allowing for approach of difficult experiences and memories. It explains why non-avoidance is helpful, while difficult initially is supportive of growth of relationship to not allow difficulties to expand or root over time. Openness. MDMA can assist in increased openness to experience and decrease neuroticism. The ability to engage in interactions may be supported by the release of cortisol and paired with oxytocin. That could create shared intentions and establishing as a value to bring through the process. Attachment/safety, decreased feelings of threat, increased feelings of interpersonal trust. Skills to engage in difficult conversations, take breaks, and re-engage, creating a template for future experiences. Bonding or social intimacy. So MDMA, oxytocin, which MDMA causes to release, supports feelings of social bonding. MDMA helps increase cooperation and feelings of trustworthiness. It increased experience of social intimacy following MDMA-assisted couple therapy. So couples engaging in the whole process together. And then the last one, relationship satisfaction. Improved relationship satisfaction, decreased distress in MDMA-assisted couple therapy, and encouraging shared experiences, engagement together in the therapeutic process. And that is just some of the ways that they have seen that so far it seems MDMA can be helpful in couples therapy.
This image from Cornerstone of Recovery, it basically just shows, so normally we've got enzymes and neurotransmitters, receptors, etc. We got the axon and the dendrite and all that. But then with benzodiazepines, they bind to receptors to inhibit neurotransmitter release from the axon here. And the typical routes of administration, mainly oral, Like usually you just like take the pill, or some people can snort it too, but that's not as common.
And then we'll go into the pharmacology of benzodiazepines. So, benzodiazepines increase effectiveness of the endogenous chemical GABA to decrease the excitability of neurons. It reduces communication between neurons and can have a calming effect, or leading to its calming effect. GABA controls the excitability of neurons. GABA receptor is a protein complex located in the synapses between neurons. GABA receptors have two binding sites for the neurotransmitter gamma-aminobutyric acid, or GABA. A subset of GABA receptor complexes also contain a single binding site for benzodiazepines. Binding of benzodiazepines to this receptor complex does not alter the binding of GABA. Benzodiazepine binding acts as a positive allosteric modulator, increasing the total conduction of chloride ions across the neuronal cell membrane. When GABA is already bound to its receptor, hyperpolarizes the neuron's membrane potential. There's a difference between resting potential and threshold potential, which is increased, leading to firing being less likely. Activation of different GABA receptor subtypes by benzodiazepines may result in distinct pharmacological actions. Referred to as benzodiazepine receptors is what those are. And then GABA receptors that are made up of different combinations of subunit subtypes have different properties, different distributions in the brain, and different activities relative to pharmacological and clinical effects. Benzodiazepine ligand locks the benzodiazepine receptor into a conformation in which it has greater affinity for the GABA neurotransmitter. This increases the frequency of the opening of the associated chloride ion channel and hyperpolarizes the membrane of the associated neuron. There's an inhibitory effect of the available GABA is potentiated, leading to sedative and anxiolytic effects. The benzodiazepine class of drugs also interacts with peripheral benzodiazepine receptors. These can modulate the immune system and are involved in the body's response to injury, and also function as weak adenosine reuptake inhibitors. Peripheral binding sites for benzodiazepines are present in immune cells and the gastrointestinal tract.
All right, so next we've got the side effects of benzodiazepines. The most common ones are drowsiness, lightheadedness, confusion, unsteadiness, especially in older people who may fall and experience injuries. Then we have dizziness and slurred speech, muscle weakness, memory problems, constipation, nausea, feeling sick, dry mouth, or blurred vision. And then there's some less common side effects that include headaches, low blood pressure, increased saliva production, digestive disturbances, rashes, sight problems such as double vision, tremors or shaking, changes in sexual desire, incontinence, loss of bladder control, and difficulty urinating. So there's also some paradoxical effects, and these are side effects which are the opposite of what the medication is supposed to do. So for benzodiazepine, they include aggressive behavior, agitation, anxiety, delusions or strongly held beliefs that other people don't share. There's depersonalization, feeling detached from your surroundings. Then depression, derealization or feeling out of touch with reality, hallucinations, inappropriate behavior with loss of normal inhibitions, irritability, nightmares, personality changes, psychosis, rages, restlessness, and suicidal thoughts or behavior. And then these effects may happen with any benzodiazepine, but they're a lot more common in children and older people and with short-acting benzodiazepines. So first we've got an image here from Binghamton EDU, and we can see here the main interaction here is the dopamine transporter being blocked by the cocaine. And then we've got, dopamine coming out. We got the cocaine. We got the transmitting neuron, or that's the axon, right? The transmitting neuron is always the axon, I think. And
yeah.
the receiving neuron is the dendrite. I think I said that right. Is that what it's called? Right?
Yeah.
Okay. It's been a while since I've been to school. But yeah, so then we've got the dopamine receptors down here. And then the intensity of effect that shows. So the common routes of administration. So for cocaine, typically people will either snort or inject it. Some people will smoke it with weed or lace weed with it or whatever. And then there's crack, which is typically either smoked or injected. And that's typically how people use those different drugs. No, they're the same drug. They're just made a little bit differently.
And then we'll be going over, again, the pharmacology here. So it causes a blockade of the dopamine transporter protein. Cocaine binds tightly at the dopamine's transporter, forming a complex that blocks the transporter's function. So the dopamine transporter can no longer perform its reuptake function, and thus dopamine accumulates in the synaptic cleft. This ends up activating postsynaptic dopamine receptors, which makes the drug rewarding and promotes the compulsive use of cocaine. It also can affect certain serotonin or 5-HT receptors. It can antagonize the 5-HT3 receptor, and then the 5-HT2 receptor, particularly the subtypes 5-HT2A, 5-HT2B, and 5-HT2C, are involved in the locomotor activating effects of cocaine. Sigma receptors are also affected by cocaine. Specific receptors has been demonstrated to function on are MMDA and the D1 dopamine receptor. It can also block sodium channels, thereby interfering with the propagation of action potentials. It can act as a local anesthetic and also functions on the binding sites to the dopamine and serotonin sodium-dependent transport area as targets as separate mechanisms from its reuptake of those transporters. Cocaine has some target binding to the site of the kappa opioid receptor. And cocaine also causes vasoconstriction, thus reducing bleeding during minor surgical procedures. The important role of circadian mechanisms and clock genes and behavioral actions of cocaine. And then another effect is suppressing hunger and appetite by increasing co-localization of sigma. I don't know what that symbol is, but receptors in ghrelin GHS-R1A receptors at the neuronal cell surface, thereby increasing ghrelin-mediated signaling of satiety. Being hungry.
Yeah. All right, and then we're going to talk about a couple of the short-term effects. Hold on. So they may make the user feel euphoric, energetic, talkative, mentally alert, and hypersensitive to sight, sound, and touch. And it can also temporarily decrease the need for food and sleep. Some users find that it helps them perform simple physical and intellectual tasks more quickly, although others experience the opposite effect. Let's see here. And the physiological effects include constricted blood vessels, dilated pupils, and increased body temperature, heart rate, and blood pressure. Large amounts can intensify the high, but also lead to bizarre, erratic, and violent behavior. Some users report feeling restless, irritability, anxiety, panic, and paranoia. And they may also experience tremors, vertigo, and muscle twitches. And then there's also severe medical complications that can occur, including cardiovascular effects like disturbances in heart rhythm and heart attacks, neurological effects including headache, seizures, stroke, and coma, and gastrointestinal complications including abdominal pain and nausea. In rare instances, sudden death can occur on the first use of cocaine or unexpectedly thereafter, and the deaths are often the arrest of cardiac arrest and seizures. And then many cocaine users also combine their use with alcohol, and the combination can be particularly dangerous. The two substances react to produce cocaethylene, which may potentiate the toxic effects of cocaine and alcohol on the heart. The combination of cocaine and heroin is also very dangerous. And this can lead to taking a high dose of heroin without realizing it. Because cocaine wears off sooner, this can lead to a heroin overdose, in which the user's respiration dangerously slows down or stops. So then what about long term? Let's see. So it can lead to increased irritability, restlessness, panic attacks, paranoia, and even full-blown psychosis, in which the individual loses touch with reality and experiences auditory hallucinations. Let's see. Regularly snorting cocaine can lead to a loss of smell, nosebleeds, problems swallowing, hoarseness, and overall irritation of the nasal septum, leading to a chronically inflamed runny nose. Smoking crack cocaine damages the lungs and can worsen asthma. And people who inject cocaine have puncture marks with tracks, as they're known, most commonly in their forearms, but they could be anywhere. And they're at risk of contracting infectious diseases like HIV and Hep C, and they may also experience allergic reactions. And it also damages many other organs in the body, reducing blood flow to the gastrointestinal tract, which can lead to tears and ulcerations. Many chronic users can lose their appetite and experience significant weight loss and malnourishment. It has significant and well-recognized toxic effects on the heart and cardiovascular system. And chest pain feels like a heart attack is common and sends many cocaine users to the emergency room. The use is linked to an increased risk of stroke, as well as inflammation of the heart muscle, deterioration of the ability of the heart to contract, and aortic ruptures. There have been reports of intracerebral hemorrhage or bleeding within the brain from long-term use, and balloon-like bulges in the walls of the cerebral blood vessels. Movement disorders, including Parkinson's disease, may also occur after many years of cocaine use. And studies suggest that a wide range of cognitive functions are impaired with long-term cocaine use, like sustaining attention, impulse inhibition, memory, making decisions involving rewards or punishments, and performing motor tasks. So those are some long-term effects. And then we have specific, and that was for cocaine, and then we have the American Addiction Centers with the effects of crack use. Going to be similar, but a little different. So some of the potential dangers associated with using crack include lung damage, respiratory problems, increased blood pressure, tachycardia or racing heartbeat, and onset of psychotic symptoms. And because crack is produced in unregulated settings from cocaine of inconsistent purity and quality, the precise effects can vary greatly, but they generally include a euphoric rush, increased alertness, excited state, decreased appetite, dilated or enlarged pupils, increased heart rate, intense craving for another dose shortly after the high subsides. And though these can vary as widely as the positive effects listed above, commonly reported side effects include irritability, anxiety, headache, depression, aggressive paranoid behavior, abdominal pain, and sudden death due to heart attack or stroke. Let's look at the brain areas affected by methamphetamine neurotoxicity from the Psychiatric Times. So as we can see here in the frontal cortex and the hippocampus, there is cell death. And then in the striatum, there is cell death and damage to the dopamine nerve terminals. So the common routes of administration for methamphetamine include oral, smoking, hot railing, or injection, which hot railing is you basically are inhaling vapor through your nose. And amphetamines are commonly taken either orally or by snorting them. And then we have the amphetamine image here of how amphetamines interact with the brain. So number one, we have the amphetamine neurochemistry. Then we've got the dopamine and the amphetamine here. So the dopamine storage vessel, the dopamine transporter reuptake, and then the dopamine receptors are down here, and then we've got the postsynaptic terminal. I'm not sure, I don't see the amphetamine in the chart here. I just see it listed in the key, but that's okay. And so there's that image. And then we have the effect on dopaminergic pathways and key to neuroanatomical regions. So in red, we've got the mesolimbic pathway, this red line. Then this green line is the mesocortical pathway. And then this blue is the nigrostriatal pathway. So there's increased extracellular DA targets, cortical and subcortical regions involved in visuomotor control. So I think that's hand-eye coordination. And then we have DA dysregulation alters information processing capabilities, so top-down control, via deficits in collecting, maintaining, and updating of visual information. And then reduced top-down control affects attentional regulation of visual information. So the next we have the altered visuomotor control. It can decrease saccadic latency or velocity, accuracy of SPEM, and continuous visual tracking. And then we have the implication for neurobehavior. So stereotype rigidity in scanning behavior or tunnel vision, less efficient processing of the visual environment, and impaired performance during complex visually guided tasks of high cognitive load, like driving. And I'm assuming this is on the neurotypical brain for the neurobehavior. And because otherwise, why would they give out the medication to people who have like ADHD?
Yeah.
You know what I mean? Like,
yeah. I mean, unless you take like too high of a dose, then you'll.
That's true too. Yeah. If you do if you're abusing it, then that's different.
Yes. Yeah.
If you're like taking it medicinally and recreationally are two different things.
Yeah.
So we've got that.
Okay. And then we'll go just into the pharmacology. So we're going to just start with methamphetamine, and that is a potent full agonist of trace amine associated receptor 1, or TAAR1, which is a G protein coupled receptor that regulates brain catecholamine systems. Activation of TAAR1 increases cyclic adenosine monophosphate, or CAMP, production and either completely inhibits or reverses the transport direction of the dopamine transporter, norepinephrine transporter, and serotonin transporter. Triggers transporter phosphorylation via protein kinase A, or PKA, and protein kinase C, or PKC, signaling. ultimately resulting in the internalization or reverse function of monoamine transporters. It increases intracellular calcium, producing dopamine efflux. TAR1 has been shown to reduce the firing rate of neurons through direct activation of G protein coupled inward the rectifying potassium channels. TAR1 activation by methamphetamine and astrocytes appears to negatively modulate the membrane expression and function of EAAT2, which is a type of glutamate transporter. It inhibits synaptic vesicle function by inhibiting VMAT2, which prevents monoamine uptake into the vesicles and promotes their release. The outflow of monoamines from synaptic vesicles into the cytosol, or intracellular fluid, of the presynaptic neuron, and their subsequent release into the synaptic cleft by the phosphorylated transporters. And then agonists of the alpha-2 adrenergic receptors and sigma receptors with a greater affinity for...
I think it's omega. I'm not sure.
Is it omega or sigma?
It might be sigma, actually, yeah. I was just thinking that too.
Just because it's talking about like the sigma receptors. So I assume it's sigma. So like for sigma 1, then sigma 2. So greater affinity for sigma 1 than sigma 2. And inhibits monoamine oxidase A and monoamine oxidase B. Sigma receptor activation by methamphetamine may facilitate its central nervous system stimulant effects and promote neurotoxicity within the brain. Dextromethamphetamine is a stronger psychostimulant, but levomethamphetamine has stronger peripheral effects, a longer half-life, and longer perceived effects among addicts. At high doses, both enantiomers of methamphetamine can induce similar stereotypy and methamphetamine psychosis, but levomethamphetamine has shorter psychodynamic effects. And then we're going to move on to the pharmacology of amphetamines. And we're going to, I think Adderall is the main one. So, or there's probably others, but we're just going to. So, amphetamine, the active ingredient of Adderall, works primarily by increasing the activity of the neurotransmitters dopamine and norepinephrine in the brain. It also triggers the release of several other hormones, for example, epinephrine, and neurotransmitters like serotonin and histamine, as well as the synthesis of certain neuropeptides, cocaine and amphetamine-regulated transcript, CART peptides. So, both active ingredients of Adderall, dextroamphetamine and levoamphetamine, bind to the same biological targets, but their binding affinities differ somewhat. Dextroamphetamine and levoamphetamine are both potent full agonists of trace amine-associated receptor 1, or TAR1 again, and interact with vesicular monoamine transporter 2, VMAT2, with dextroamphetamine being the more potent agonist of TAR1. Consequently, dextroamphetamine produces more CNS stimulation than levoamphetamine. However, levoamphetamine has slightly greater cardiovascular and peripheral effects. In the absence of amphetamine, VMAT2 will normally move monoamines, example dopamine, histamine, serotonin, norepinephrine, etc., from the intracellular fluid of a monoamine neuron into its synaptic vesicles, which store neurotransmitters for later release via exocytosis into the synaptic cleft. When amphetamine enters a neuron and interacts with VMAT2, the transporter reverses its direction of transport, thereby releasing stored monoamines inside synaptic vesicles back into the neuron's intracellular fluid. Meanwhile, when amphetamine activates TAR1, the receptor causes the neuron's cell membrane-bound monoamine transporters, so the dopamine transporter, norepinephrine transporter, or serotonin transporter, to either stop transporting monoamines altogether or transport monoamines out of the neuron. In other words, the reverse membrane transporter will push dopamine, norepinephrine, and serotonin out of the neuron's intracellular fluid and into the synaptic cleft. So, in summary, by interacting with both VMAT2 and TAR1, amphetamine releases neurotransmitters from synaptic vesicles into the intracellular fluid, where they subsequently exit the neuron through the membrane-bound reversed monoamine transporters. And then we're just going to briefly also mention lisdexamfetamine. And lisdexamfetamine is an inactive prodrug that is converted in the body to dextroamphetamine, a pharmacologically active compound that is responsible for the drug's activity. And another name for this one is Vyvanse. So, after oral ingestion, lisdexamfetamine is broken down by enzymes in red blood cells to form L-lysine, a naturally occurring essential amino acid, and dextroamphetamine. The conversion of lisdexamfetamine to dextroamphetamine is not affected by gastrointestinal pH and is unlikely to be affected by alteration in normal gastrointestinal transit times. The optical isomers of amphetamine, for example, dextroamphetamine and levoamphetamine, are TAR1 agonists and vesicular monoamine transporter 2 inhibitors that can enter monoamine neurons. This allows them to release monoamine neurotransmitters from their storage sites in the presynaptic neuron, as well as prevent the reuptake. So basically then, once it gets converted to the dextroamphetamine, it does the same as Adderall then. And lisdexamfetamine was developed with the goal of providing a long duration of effect that is consistent throughout the day with reduced potential for abuse. The attachment of the amino acid lysine slows down the relative amount of dextroamphetamine available to the bloodstream. Because no free dextroamphetamine is present in lisdexamfetamine capsules, dextroamphetamine does not become available through mechanical manipulation, such as crushing or simple extraction. A relatively sophisticated biochemical process is needed to produce dextroamphetamine from lisdexamfetamine, as opposed to Adderall, which contains roughly equal parts of racemic amphetamine and dextroamphetamine salts. Lisdexamfetamine is a single enantiomer for dextroamphetamine formula. And then, I guess, studies conducted do show that lisdexamfetamine dimesylate may have less abuse potential than dextroamphetamine and an abuse profile similar to diethylpropion at dosages that are FDA approved for treatment of ADHD, but still has high abuse potential when this dosage is exceeded by over 100%.
Yeah, I don't know. I mean, I'm just gonna say with like it, I really don't see it having less abuse potential. There's, I don't know, people still abuse it a lot. I mean, and that doesn't mean people shouldn't use it medically, but like a lot of people just use it recreationally, just like they would with Adderall. And I mean, they
it still causes the same effects. It's just the main thing is like you can't snort lisdexamfetamine. Like it isn't going to activate as quickly as Adderall would. So people are more likely to abuse Adderall if they're trying to get like a quick high, because lisdexamfetamine is going to take time because it has to do that conversion to the active molecule. It doesn't mean that it can't be abused, obviously.
Right.
But I think so in their theory, because it takes longer, it is going to be less likely to be abused. But yes, it is still obviously abused because it does cause like the dopamine effect.
I guess when they say less likely to be abused, like, I guess if you think of it in the scenario when you can pick between one or the other, people would probably pick the Adderall over the Vyvanse if they're trying to use it recreationally. But like, I mean, yeah, I don't know. It's still, I mean, and they do say there is still high abuse potential.
Yeah.
But yeah, I just wanted to point that out. I don't know. I just felt the need to point that out.
Yeah.
That, you know, that does happen quite a bit. But anyways, so we're going to go over the side effects of meth specifically. And some of these side effects, most of them would also, they can apply to amphetamines as well, especially taken at high doses. So yeah, initial side effects include rapid heart rate. And this is from American Addiction Centers. So side effects, rapid heart rate, increased blood pressure, anxiety, insomnia, increased respiratory rate, elevated body temperature, paranoia, aggression and violence, convulsions, tremors, death, or cardiovascular issues such as stroke and heart attack. And then there's other adverse long-term effects of chronic methamphetamine use, or even chronic amphetamine use in, high doses, or for people who don't need it medically. And they may include stimulant addiction development, changes in the brain structure and function, decreased motor skills, verbal learning declines, chronic anxiety. Then we've got repetitive movements, visual and auditory hallucinations, delusions, paranoia, chronic anxiety, aggressive or violent behaviors, mood disturbances, and then memory loss, malnutrition, and severe dental problems. And individuals who abruptly stop taking crystal meth after long-term use. We'll talk about a little more of these symptoms, but in another episode. But if you stop after long-term use, withdrawal symptoms may include fatigue, depression, anxiety, and drug cravings, and more. So just to clarify, I'm going to start off here. According to the CDC, opiates refer to natural opioids such as heroin, morphine, and codeine, while the term opioids refers to all natural, semi-synthetic, and synthetic opioids. So we're going to look at this image here. The source is adapted from Hugh Guinea, Wikimedia Commons, from Ian Hayden and staff. So this is opioids do more than stimulate the brain's pleasure center. Neuroscientists are still learning where drugs like heroin and fentanyl target and how repeated exposure to them reshapes the brain. So here's what we know so far. The prefrontal cortex and the central reward pathway. There is a natural link between pleasure and complex thoughts, such as decision-making and planning. With long-term opioid abuse, the pathway becomes dysregulated. And then the amygdala in the midbrain. The urge to keep using opioids is born here. The midbrain helps steer behavior based on what it has experienced. And then the locus coeruleus and the brainstem. So opioids can suppress the brainstem's ability to control breathing and heart rate. During overdose, this can kill the user. So, typical routes of administration. It's really going to depend on what you're using specifically. But all in all, they can be oral, such as swallowing a pill. You can snort, smoking, and injecting. So that's typically how people use opioids and opiates.
And then we're gonna move again into the pharmacology here. So, opioids bind to specific opioid receptors in the nervous system and other tissues. There are three principal classes of opioid receptors: mu, kappa, and delta, although up to 17 have been reported and include the epsilon, iota, lambda, and zeta receptors. There are three subtypes of mu receptor: mu1, mu2, and the newly discovered mu3. Opioid receptor like receptor 1, ORL1, which is involved in pain responses as well as having a major role in the development of tolerance to mu-opioid agonists used as analgesics. G-protein coupled receptors act on G-protein coupled receptors acting on GABAergic neurotransmission. So, response to an opioid depends upon the receptor to which it binds, its affinity for that receptor, and whether the opioid is an agonist or an antagonist. Each group of opioid receptors elicits a distinct set of neurological responses, with the receptor subtypes, such as mu1 and mu2, for example, provide an even more specific responses. Unique to each opioid is its distinct binding affinity to the various classes of opioid receptors. It is this combinatorial mechanism that allows for such a wide class of opioids and molecular designs to exist, each with its own unique effect profile. Their individual molecular structure is also responsible for their different duration of action, whereby metabolic breakdown is responsible for opioid metabolism. And then we just have a little article here from the NIH, how opioid drugs activate receptors. So, at a glance, researchers found that opioid drugs and the brain's natural opioids differ in how they activate receptors in nerve cells. And this difference may help researchers develop better treatments that are less addictive than currently available opioid drugs. So opioids work by activating opioid receptors on nerve cells, and as mentioned, they belong to a family of proteins known as G protein coupled receptors. And recent studies have found that those G protein coupled receptors that can be activated within the cell, as well as at the cell surface. And a research team set out to test whether all opioids, whether endogenous or not, bind to the same receptors in nerve cells. They designed a tiny sensor called a nanobody that generates a fluorescent signal when an opioid receptor is activated. They used that nanobody to detect endogenous opioid activating receptors on the surface of a nerve cell. And they found that activation by the endogenous opioid wasn't restricted to the cell surface. Receptor molecules entered the cell inside what is known as an endosome. There, they remained activated for several minutes. In addition to activating receptors on the nerve cell surface and in endosomes, opioid drugs had a different wave of activity. Within tens of seconds, they induced nanobody signaling in receptors in internal structures known as the Golgi apparatus and Golgi outposts. The different and more rapid ways that opioid drugs interact with these receptors may help explain their undesired side effects. And these findings could help guide the design of pain relievers that don't have these unwanted effects.
All right, now we're just going to go over a couple things here. So, possible side effects of opioids include drowsiness or sedation, dizziness, nausea and vomiting, constipation, physical dependence, and dependence often manifests itself with withdrawal symptoms where opioids are discontinued or decreased. And then tolerance. As you take repeated doses of opioids, you require increased medication or drug dosage to experience the effect of pain relief. And respiratory depression. This can occur in healthy people, especially with high doses. However, people with COPD, asthma, or other lung conditions may be even more susceptible to fatal respiratory impairment. And then we have some more here from heroin drug facts from the NIH. And then, let's see. So heroin enters the brain rapidly and binds to opioid receptors on cells located in many areas, especially those involved in feelings of pain and pleasure and in controlling heart rate, sleeping, and breathing. Let's see. And then the more short-term effects. People who use heroin report feeling a rush, which is a surge of pleasure or euphoria. And however, there are other common effects, and these include dry mouth, warm flushing of the skin, heavy feeling in the arms and legs, nausea and vomiting, severe itching, clouded mental functioning. They call it going on the nod. I've never heard someone on the street call it on the nod. Usually it's they call it nodding off. But anyways, so nodding off, which is a back and forth state of being conscious and semi-conscious. And I'm going to talk more about that in our conclusion as well. And then the long-term effects, people who use heroin over the long term may develop insomnia, collapsed veins. It says for people who inject the drug, but I mean, even people who just don't inject the drug can still have the collapsed veins. And then there's damaged tissue inside the nose of people who sniff or snort it, infection of the heart lining and valves, abscesses or swollen tissue filled with pus. That's usually from injections that go wrong. And then there's constipation and stomach cramping, liver and kidney disease, lung complications including pneumonia, mental disorders such as depression and antisocial personality disorder, and sexual dysfunction for men, and, well, I think there's sexual dysfunction for women as well. And then irregular menstrual cycles for women. And then we'll just talk about how the addiction is treated really quickly, the drugs that they use for opioid use disorders. These medications are safe, effective, and save lives. They interact with the same opioid receptors in the brain on which heroin acts, but they do not produce the same effects. So we have methadone, which is the opioid receptor full agonist. It attaches to and activates opioid receptors to ease withdrawal symptoms and cravings. And then there's buprenorphine, or Suboxone as it's also known. And that is an opioid receptor partial agonist. So it attaches to and partially activates opioid receptors to ease withdrawal symptoms and cravings. And finally, we have naltrexone, which is an opioid receptor antagonist. And it prevents heroin from attaching to opioid receptors, and it will block its effects. But you should not use alcohol or opiates if you are taking naltrexone, because it can have really, really severe side effects if you do. So let's see. They come from, opioids are made from morphine, which is a natural substance taken from the seed pod of various opium poppy plants. So heroin enters the brain rapidly and binds to opioid receptors on cells located in many areas, especially those involved in feelings of pain and pleasure and controlling heart rate, sleeping, and breathing. And then misuse of prescription opioid pain medication is a risk factor for starting heroin use. And then naloxone is the medicine that we give to treat a heroin overdose. More than one dose may be needed. And heroin can lead to addiction. Yeah, so that was that article.
And then I just have a few things here on opioid addiction, just because I was interested in what they, like the pharmacology, I guess, kind of. So, when opioid drugs infiltrate a part of the brain stem called the locus coeruleus, their receptors slow respiration, cause constipation, lower blood pressure, and decrease alertness, as we have talked about. And addiction begins in the midbrain, where opioid receptors switch off a batch of nerve cells called GABAergic neurons. Once opioids shut off GABAergic neurons, the pleasure circuits fill with another neurotransmitter called dopamine. At one stop on this pleasure highway, the nucleus accumbens. Dopamine triggers a surge of happiness. And when dopamine rolls into the amygdala, that's the brain's fear center, as we have talked about, it ends up relieving anxiety and stress. Both of these events reinforce the idea that opioids are rewarding. And in a 2017 study, it found that most patients, 81%, whose addiction started with a chronic pain problem, also had a mental health disorder. And another study found patients on morphine experience 40% less pain relief from the drug if they have a mood disorder. And then replacement medications stick to the receptors for... Oh, so I think they're saying this is why like those medications that can be used, the ones that you just mentioned, is because they stick to receptors for longer periods of time, which can help curtail those withdrawal symptoms. And then I guess it was mentioned that opioid replacement therapy does not work for fentanyl, because I think it's a different, like it does a different, because it's like a synthetic, isn't it?
Yeah.
So it's like a different mechanism.
Okay. Wait, so this is more, what you discussed was more about opiates like heroin and morphine than about fentanyl, synthetics like fentanyl.
Yeah, I think so, yeah.
Okay. So first, we're going to start with an image from UC San Diego. Right here we have the boton and the spine. We see the seltzer-3 maintained synapses, WNT5A, RYK, and Vangel-2 disassemble synapses. So we've got the synapse maintenance, and the A beta oligomers bind to the seltzer-3. I think it's cut off. I think it meant to say seltzer-3. And then we have the synapse maintenance again. But it kind of cuts off there. That is how PCP works. And then the common routes of administration are oral, injection, or smoking. Which for smoking, usually it's putting the liquid on like a joint or a tobacco, like a cigarette, and smoking that. And then PCP acts as a hallucinogen, a stimulant, depressant, and anesthetic all at the same time.
And we're going to be going again just over the pharmacology of PCP. So PCP's primary action is on the NMDA receptor. It's an NMDA receptor antagonist. Other NMDA receptor antagonists include ketamine, tilitamine, dextromethorphan, nitrous oxide, and diazoxypline, MK-801. It inhibits nicotinic acetylcholine receptors. Presynaptic nicotinic acetylcholine receptors and NMDA receptor interactions influence postsynaptic maturation of glutamatergic synapses and consequently impact synaptic development and plasticity in the brain. These effects can lead to the inhibition of excitatory glutamate activity in certain brain regions such as the hippocampus and cerebellum, thus potentially leading to memory loss as one of the effects of prolonged use. Acute effects on the cerebellum manifest as changes in blood pressure, breathing rate, pulse rate, and loss of muscular coordination. During intoxication, it acts as a potent dopamine D2 high receptor partial agonist in rat brains, and then has an affinity for the human cloned D2 high receptor. May be associated with some of the other more psychotic features of PCP intoxication, which is evidenced by the successful use of D2 receptor antagonists such as Haldol in the treatment of PCP psychosis. It has been shown to inhibit dopamine reuptake, thereby leading to increased extracellular levels of dopamine and hence increased dopaminergic neurotransmission. There's little affinity for the human monoamine transporters, including the dopamine transporter. Its inhibition of monoamine reuptake may be mediated by interactions with allosteric sites on the monoamine transporters. Studies on rats have indicated that PCP interacts directly with opioid receptors, endorphin and enkephalin, to produce analgesia. Results suggest that PCP is a highly selective ligand of the NMDAR and O2 receptor. PCP may also interact with allosteric sites on the monoamine transporters to produce inhibition of monoamine reuptake. Phencyclidine is an NMDA receptor antagonist that blocks the activity of the NMDA receptor to cause anesthesia and analgesia without causing cardiorespiratory depression. And NMDA is an excitatory receptor in the brain. Phencyclidine enters the ion channel and binds reversibly and non-competitively inside the channel pore to block the entry of positive ions into the cell, thereby inhibiting cell depolarization. And studies on rats have indicated that PCP interacts indirectly with opioid receptors, which I think that was already mentioned. So,
yeah, and then we have some of the psychological effects of PCP, and those include euphoria, disorientation, lethargy, calmness, loss of coordination, changes in body awareness, distorted sensory perceptions, hallucinations, agitation, sense of detachment, lack of concentration, memory loss, combativeness, bizarre behavior, and stupor. So, additionally, and some of these might be repeated, PCP can cause a person to experience a loss of balance and coordination, depersonalization or feelings of detachment, sound, image, and body distortion, of course, euphoria, as we mentioned, and then a loss of sensation and inability to feel pain, numbness in the arms and legs, feelings of impending doom, and acute anxiety, agitation, and mood swings. And other people may notice that the user is showing poor coordination and an unsteady gait, slurred or garbled speech or difficulty talking, bloodshot eyes and rapid eye movements, stupor or lack of movement, confusion and disorientation, a blank stare, combativeness or aggression, and bizarre behavior. There may be drooling, and it can also lead to rigid muscles, amnesia or memory loss, delusions, irregular heartbeat and low blood pressure, reduced breathing rate, chills and sweating, and dizziness, nausea, and vomiting. And high doses can lead to seizures, coma, damage to the skeletal muscles, known as rhabdomyolysis, and death. And then there's some long-term health risks that include stuttering and difficulty speaking, social isolation and withdrawal, flashbacks, anxiety, depression, problems with reasoning and memory, and suicidal thoughts. And these can last for up to a year. So we'll talk about first the withdrawal symptoms for each drug. So first we'll go over opioids and opiates. So number one, there's intense cravings, nausea and vomiting, severe muscle aches and pains, extreme sweating, extreme pains in muscles and bones, cramping in limbs, feelings of heaviness in the body, crying, jags, which is basically just teary eyes, I think, is what they're trying to say there. I've never heard it called a crying jag, but yeah, the teary eyes do happen. And then there's insomnia, fever, cold sweats, runny nose, diarrhea, and death can occur when other medical conditions are present.
And then we'll go over some withdrawal symptoms that you may experience withdrawing from marijuana. So that could be sleep difficulties like insomnia, headaches, mood changes, irritability, loss of focus, diminished appetite, cravings. You could have experience sweating, which could include cold sweats, increased feelings of depression, stomach problems, and or chills.
All right. And then with alcohol, the withdrawal symptoms include nausea, headache, anxiety, shaky hands, sweating, insomnia, and vomiting, and then delusions, hallucinations, or seizures, high blood pressure, fever, heavy sweating, confusion, and racing heart.
And then for hallucinogens, you may experience impaired memory, schizophrenia, anxiety, suicidal thoughts, depression, lessened attention span, difficulty with abstract thought, and or mental confusion.
And with MDMA specifically, withdrawal symptoms could include abnormal increase in appetite, agitation, a general dissatisfaction with life or depression, irritability, lethargy, anxiety, and excessive sleepiness.
For benzos, withdrawal symptoms that you may experience could include anxiety, panic attacks, sweating, nausea, headaches, tremors, seizures, heart palpitations, and or muscle pain.
And then for crack or cocaine withdrawals, that can include anhedonia, which is the inability to feel pleasure, depression, exhaustion and fatigue, challenges in concentration, all over body aches and pains, cravings, tremors and shakiness, chills, and anxiety.
For amphetamines or methamphetamines, some, again, withdrawal symptoms may include irritability, fatigue, anxiety, dehydration, lack of energy, weight gain, dysphoria, which is low mood, could progress to clinical depression and suicidal thoughts, insomnia, which could be followed by hypersomnia, which is sleeping too much. You could experience anhedonia, as we mentioned with the other one, the inability to think clearly, drug cravings, depression, withdrawing from others, mood swings, psychosis, fatigue and excessive sleepiness, increased appetite, and or suicidal thoughts / ideation.
All right. And then finally, for PCP withdrawals, some symptoms may include sweating, irritability, agitation, fear, anxiety, restlessness, headache, muscle breakdown, seizures, hallucinations, muscle twitching and tremors. And there's hyperactive eye movements, acidosis, elevated body temperature, depression and suicidal thoughts, diarrhea, weight loss, impaired cognitive function, mood disorders, sleep disturbances, and speech impairments.
And then some drugs that you should never quit cold turkey without medical supervision. So if you are thinking about quitting alcohol, benzodiazepines, or PCP, make sure you have a plan to visit a detox center or the ER. The possible seizures and other symptoms can make those withdrawals deadly, so medical supervision is highly recommended.
All right, and then now we're going to talk about making a plan to quit. So the best way to quit is to find a local detox center. This way you can be medically monitored during your withdrawal, and you won't be able to go out and buy more drugs as the withdrawals get worse. And if you can't go to a detox center, try your best to find somebody who can keep you company and hold you accountable for quitting as you go through the withdrawals. So consider getting medication that may counteract your withdrawal symptoms. And this can include anything from anti-nausea medication, pain medications like Advil and ibuprofen, like Suboxone or methadone from a doctor if possible, etc. And not quitting cold turkey it will increase your chances of recovery, according to research. And you also want to mentally prepare yourself for the withdrawals and cravings. A positive mindset that you'll be strong and resilient is going to help you get through your detox with more strength. You want to plan your treatment as closely to the end of your withdrawals as possible. Another option is to attend a treatment center that has its own detox center, and that'll help you quickly transition into treatment after detox. Whether you opt for inpatient or outpatient treatment is your choice, and either choice is valid, honestly. It really just depends on you and your needs. You want to be ready to cut certain people out of your life. If you're truly looking to quit, having active users in your life is going to be detrimental to your early recovery. And once you're in a later stage of your recovery, you're most likely just going to see that it's best to keep these people out of your life anyways. At least most of them. And you want to build a solid support system. If you're struggling to feel support, or you just want to have others in your life who understand what you're going through, support groups are a great mechanism. While there's AA, NA, all of those types of anonymous groups, they can be a good option for some people. But if you're looking for a different program, or even if you just want to do an additional, if you want to go to additional group besides AA or NA, or whatever your anonymous group is, I would recommend Smart Recovery. Smart Recovery is a cognitive-based approach to recovery. It's basically CBT for addiction. And it's also a support group. So I really like Smart Recovery, honestly. And you can also choose to go to multiple types of meetings, like I said, and support groups, both related to addiction and any other mental health issue you might be struggling with, if that's applicable for you. And finally, you want to start building a plan for avoiding relapse. If you choose to go to treatment, they're most likely going to help you with this plan towards the end of your treatment. But it doesn't hurt to start beginning the planning of how to avoid tempting situations, and just learning how to say no if someone offers you something, because having that plan before you work on it in your treatment program, like planning it ahead of time, will help you, because you honestly never know whether you're in inpatient or outpatient treatment. In inpatient treatment, someone could smuggle a drug in and offer you some, and you want to have a plan for that. Or if you're in outpatient treatment, obviously, like one of your old friends that you're trying not to talk to can hit you up and ask you if you want anything, or your old dealer or whatever. And you just want to have a plan of how to avoid that if you're really trying to quit. So I'll start off by saying, as far as alcohol goes, like I've never been a fan of alcohol. I just have like a naturally high tolerance to it, and I usually just get sick before I can get drunk. So it usually makes me feel like, when I am drunk, it usually makes me feel like my inhibitions are lower. It gives a warm feeling to my body and makes me a little less coordinated. And the amount of time the drunk feeling will last is going to depend on how much you drink. So if you drink 1 unit, or like 1 drink, you're going to be drunk for an hour. But if you drink 12, you'll be drunk for about 12 hours. So it's about an hour a drink. And that's going to vary from person to person as well, but that's just kind of the general average. And then with cannabis, I've used it for recreational and medical use. It has helped me with PTSD symptoms, stabilizing my mood, and keeping me kind of grounded. It helps a little to balance my blood sugars and manage my chronic pain. Marijuana use isn't for everybody, but it can help many people with both medical issues and through recreational use. So marijuana usually makes me feel more kind of in touch with reality, I guess, personally. Makes me feel physically like I'm weighted down and relaxed. For me, I usually just use at night, because it can impact my motivation and my ability to focus sometimes. For the first time users, it'll probably impair you a lot more. But for you, it's going to feel similar to like a psychedelic experience, reframing your thinking of the world, altering your perceptions to make it more vivid and colorful, increasing your hunger, and being able to enjoy things you might not have enjoyed as much if you were sober. Although this last part's kind of true for a lot of drugs, it seems to be especially true for cannabis in my experience. And the high typically lasts around 2 hours for cannabis. And then as far as dissociatives go, one thing I noticed is that they decreased my feelings of empathy. That was probably the biggest feeling I noticed. And whether it was salvia or DXM, these drugs made me feel extremely numb and complacent with my surroundings. The high will last for different amounts of time depending on the drug. Salvia lasts roughly 10 to 20 minutes, while DXM can last for 5 to 6 hours. And then my experience with hallucinogens has been pretty spiritual. It's really reshaped the way I view the world personally, and it gives feeling to the fact that we're all connected as different parts of the universe. And it makes me feel energetic, and the hallucinations are usually just altered versions of reality. Like, I've never seen something that wasn't actually there, but I see like the walls breathing, or I see images from the design of a popcorn ceiling, for example. And you do need to be careful with how often you use them, though. Personally, I used psychedelics for 3 weekends straight in the past one time. And I ended up getting really sick because that frequent drug use weakened my immune system. But the high for psychedelic, like hallucinogen psychedelics, usually last for around 6 to 10 hours. Well, at least with LSD and psilocybin. And then I know DMT usually lasts around 10 to 20 minutes, but it feels like a long time. It feels a lot longer than that, but it only lasts for about 10 to 20 minutes with DMT. And yeah, but so the amount of time it lasts is really going to depend on the hallucinogen as well. And then with MDMA, when I would take in the past, it would increase my energy. I would feel like a love more intensely, I guess, or I would feel more of a love feeling towards more people. And it also had a psychedelic feeling to it, but it's less spiritual than the other psychedelic hallucinogens. And it's much more likely to be laced with drugs like coke, meth, or even heroin. But it still gave me a feeling of connectedness with the world, and it combined with the increased feeling of love. And it also leads to this, well, we call it being floored. And being floored just means that your body is so heavy and you usually need to sit down. Like, it's just extreme weight on your body, but not in a painful way. And that high will usually last for around 4 to 6 hours. So yeah, and then when I did benzos, there were a couple times I would black out, but when I wasn't blacked out, or even when I was, I guess, they usually caused me to feel my anxiety fade away, for sure, which is their job. And they numbed all my emotions in general. They made me forgetful, but it still felt good. Obviously, it's a drug. They tend to do that. But this drug had more of a psychological effect than any kind of physical effects that I could think of, besides slightly alleviating the pain I typically have. But I think that might be because some of my pain is linked to like trauma and the anxiety caused by PTSD. And overall, I'd say this drug probably did, I won't say this as a fact, but like, at least it felt like it was doing the most damage to like my brain and my memory, honestly. And the amount of time the high will last is going to depend on if you're taking a short acting, intermediate acting, or a long acting benzo. So now let's get down to my favorite, the opioids. So opioids and opiates, they're definitely the most addictive drugs for me. They made me feel like it basically, like physically, it feels like you're in a warm bathtub drinking like a hot cup of tea. It just feels like there's like a warm blanket wrapped around you. And another part of the high was nodding off. And that's basically when you close your eyes and like typically you kind of picture yourself somewhere that you're not. And you really feel like you're there until you snap out of the nod. So it's kind of like a dream, but like you're still awake. Like you can still, if someone like says your name, you might hear them. It's kind of like the first stage of sleep almost, like of the sleep cycle is kind of what it is like. And an example, and this one would happen to me a lot. One example though, it's like you close your eyes and you think you're driving a car, and then you open your eyes and you're just sitting on the couch in reality. So like that happened. Like I said, that happened to me a lot. And they also made me feel love much more intensely, similar to MDMA in that sense. But the withdrawals were the worst for me, at least. The first time I withdrew, I did it cold turkey, and the withdrawals lasted for about 2 weeks. Well, the pain lasted for like 6 weeks, but like the withdrawal symptoms lasted for about 2 weeks for me. And heroin was my drug of choice, as they call it, because the feeling it gives you is just really addictive. And for my advice, if you do want to try it, you want to keep the mindset that you're not going to let it take over your life, and that you're going to stop when the bag runs out. And this isn't always going to prevent addiction, obviously, but going into using drugs in general with the mindset that you'll get addicted, it kind of creates a self-fulfilling prophecy in a sense. It makes it more likely for you to become addicted. And the high for opioids usually lasts around 2 to 4 hours, my experience, and the withdrawals set in after about 8 to 12 hours. And then, while I do use amphetamines as a medication for my ADHD, I don't use meth anymore. These two drugs had similar side effects, though to very different degrees of severity. Very different. They help me to focus, give me motivation, and increase my energy. And while meth also made me violent and extremely paranoid, amphetamines obviously do not, or I would not be taking them if they did. And if I took a higher dose of amphetamines, I might experience those side effects. But I really don't have any interest in abusing my meds, honestly. So, that wouldn't really apply to me. And I do have ADHD. So if you don't have ADHD, like drugs like Adderall and Vyvanse, drugs like Adderall and Vyvanse will probably impact you in a somewhat similar way to meth, but to a lesser degree. And cocaine gave me a similar feeling, but with more euphoria and less of the paranoia. However, the cocaine high does not last anywhere near as long as the meth high lasts. Cocaine and crack, they last for around 20 minutes. I've never done crack though, but cocaine lasts for around 20 minutes, and meth lasts for around 8 to 12 hours.
I think that was good experience sharing. Then people can, I think it's, people can relate, sometimes, so.
Yeah, or if they're just wondering what it feels like if they've never done it and they don't want to go out and do it,
Yeah.
Then they'll just have an idea of what it does. All right, so we want to thank everyone who's been watching, liking, and sharing. We just want you to know we really do appreciate you, a lot.
Yes, and we are just excited to have you guys along on this journey with us as we kind of just see where KSSP podcast goes. And as always, you can leave a comment below if you have any topics you want to hear us discuss in future episodes.
You can reach out to us on Facebook, YouTube, Instagram, Twitter, and TikTok. And we do occasionally Twitch live stream as well, so make sure to follow us there to get notified when we do.
And don't forget to give this video a like, as well as follow or subscribe to our other social media accounts, and turn on notifications so that you get notified when our new content comes out. Otherwise, we will see you all next time.